Hi everybody, thanks so much for watching this video. So today I want to talk about intracranial hemorrhage. I'm going to discuss the differences between traumatic and non-traumatic intracranial hemorrhages. And by the end of this video, I want you to be able to distinguish between the two and know what steps are important in the management of these two conditions. So first off, the difference between traumatic and non-traumatic intracranial hemorrhage really just lies in what it sounds like. So traumatic is somebody who hits their head and gets a bleed. It could be epidural, it could be subarachnoid, it could be subdural, doesn't really matter. Non-traumatic is generally secondary to an aneurysm and is often preceded by some hypertension. So let's just keep that in mind when we talk about the management of these two conditions. So first and foremost, I want to discuss the importance of the cerebral perfusion pressure, because I think this is a very important concept to understand when we talk about the management of raised intracranial pressure and why it matters in the context of a bleed in the brain. So the cerebral perfusion pressure is equal to the intracranial pressure minus the mean arterial pressure. So let's keep that in mind. So this here is actually what perfuses the brain. Okay, so CPP is really an extremely important aspect of when we talk about the management of this condition. So let's start off with a case. So let's say that we have a 50-year-old farmer presents to the emergency department with a fall from a ladder, hit head, and the GCS is, let's say, 8. So pretty much quite altered, and there's concern about airway protection. So patient rolls into the emergency department, and you decide that you want to intubate that patient. So, of course, the first thing that we're going to do is put that patient onto monitors. And so we find out that this gentleman's blood pressure is, let's say, 190 over 100. So, of course, that's quite high. There's an obvious occipital hematoma, let's say. So we're thinking that this is probably an intracranial hemorrhage. So let's say his heart rate right now is 100 beats per minute. Rest rate is 20, and his temperature is, let's say, 36.0. Oxygen saturation is 99% on room air, and the blood glucose is 9. So right now, his vitals are looking relatively good, but this blood pressure is elevated. So coming back to that CPP equation, so there's concern that there's an intracranial hemorrhage here. So if the intracranial hemorrhage is truly present, that would raise the ICP. The brain wants to continue to manage that CPP and keep the CPP the same, or that cerebral perfusion pressure. So what does it need to do to the mean arterial pressure? Well, it needs to increase it. So that patient's blood pressure is going to increase. And so this is to be expected in someone with an intracranial hemorrhage. Of course, there are other things that can be causing a raised blood pressure in the context of altered level of consciousness. So let's not forget about a differential diagnosis here. But for all intents and purposes, we'll assume that this patient likely has an intracranial hemorrhage. So the patient's blood pressure is elevated. Now the question becomes, how do we intubate that patient? We don't necessarily want to raise that pressure anymore. Could potentially cause more bleeding. When it comes down to it, it's really just doing what's in the best interest of the patient and what's going to protect that patient the best. So if there's time, there are some things that we can do to try to neuroprotect that patient during intubation. So we can call it a neuroprotective intubation. So for example, there's some evidence for potentially providing the patient with fentanyl about 3 to 5 minutes before the intubation. And that's going to actually be quite a big dose. So we're talking something along the lines of 4 micrograms per kilogram. So if he's 100 kilos, that would be 400 micrograms, in which case, a lot of people would look at that number and say, holy cow, that's a lot. And of course, the intention is that when you give this medication, you're going to be planning to intubate anyways. You're going to have all your airway equipment ready at the bedside anyway. So if the patient does become apneic with that drug, you can still manage that patient's airway. The entire point of doing this is to try to blunt the laryngeal reflex that causes an increase in heart rate and blood pressure, increases the shearing forces that could potentially cause more injury to the brain and more bleeding in the brain. So we can certainly do that. Of course, time is of the essence here. So if we don't have time, then that's fine. We can just go ahead and do our typical RSI. But let's say that we're going to give this gentleman about 400 micrograms of fentanyl prior to the intubation. He weighs 100 kilograms. And then we decide to push rocuronium, let's say 1.2 milligrams per kilogram, and then that patient is intubated. So the patient's now intubated. Thankfully, because we gave that fentanyl, the blood pressure is still, let's say, 185/90 post-intubation. Okay, so we get the CT head, and the CT head shows that there's a large subdural. Okay, and it's causing mass effect. So there's certainly concern about raised intracranial pressure. So of course, the thing that we need to do here is get neurosurgery involved. The thing that's going to save this patient's life is really just some kind of decompression in that intracranial space. There's not enough room for that blood to go, and that patient likely is going to need surgery, whether it's a drain or a craniotomy, depending on what neurosurgery wants to do. But we need to get neurosurgery involved. However, in the meantime, there are a few things that we can do to try to protect the brain and to maintain adequate cerebral perfusion pressure. So, what can we do in the emergency department or in the ICU? So, number one, we can raise the head of the bed to about 30 degrees. Now, that's going to reduce the intracranial pressure. Let's go back to this equation. So that's going to reduce that intracranial pressure and try to maintain CPP. We can give the patient hyperosmolar agents. So hyperosmolar agents include mannitol and include 3% saline or hypertonic saline. Just different name for the same thing. So 3% saline is generally what's being recommended now across the board in emergency departments and critical care units for the initial management of raised intracranial pressure. You may find that some neurosurgeons prefer mannitol. It really, at the end of the day, there's no evidence to suggest that one is necessarily that much better than the other. Hypertonic saline is generally more accessible, easier to dose. So what we're going to do is generally give 250 cc's over about 10 to 15 minutes. So you're going to run that as a bolus, which is quite fast, but it's very much needed in this case. Other things that we can do is decrease the end tidal CO2. There used to be a recommendation to completely blow down that CO2 to like 2025, which is no longer recommended. There's been more harm done than good in those cases. So what we're trying to do in this case instead is just kind of maintain a normal end tidal CO2. So you're going to target about 35 or so. Okay. Blood pressure is another question. So blood pressure is something that comes up often in intracranial hemorrhage. So there's a couple of differences. This is where some of the differences lie when it comes to traumatic versus spontaneous intracranial hemorrhage. So blood pressure in a traumatic intracranial hemorrhage doesn't matter as much. Again, remember that the spontaneous hemorrhages are often preceded by some kind of hypertensive crisis. The hypertension is really what's driving that bleed and continuing that bleed. So in this case, we don't really want to, in a traumatic bleed, we don't really want to be aggressive at decreasing the blood pressure. We can actually cause more harm than good. Of course, it's going to be at the clinician's discretion. There's not great evidence for a number as far as what we should target. If the pressure is 200 or more systolic, it might be reasonable to give something like labetalol or esmolol, but it's not an absolute indication, so not needed. So blood pressure control, I'm going to say control, not needed. In a spontaneous bleed, this is more important. So we want to target around 140 to 160 millimeters mercury systolic. Again, this is important because the driver of that bleed is often going to be because of the fact that the patient had some kind of hypertensive crisis before or had hypertension sort of underlying this condition. So we want to be more aggressive with that. So what we can do is give labetalol, and we can give pushes, or we can start an infusion. There's other things other drugs that we can give. Labetalol is not the only one. It's just one that I see used quite commonly. So number 5 and number 6 are probably the most important things. And And I want to, it doesn't necessarily have to do with reducing the intracranial pressure, but these two things have actually been shown to reduce mortality in raised intracranial pressure patients, in particular bleeding patients with intracranial hemorrhage. So euglycemia and normothermia. This is absolutely paramount. So probably the most important. So let's say that, in this case, we do all of these things. We give the patient, raise the head of the bed, give them hyperosmolar agents. We reduce the end tidal. Again, we don't necessarily need to control the blood pressure much. His pressure is around 180 or so systolic, so I'm not really too concerned about that. It's a traumatic intracranial hemorrhage. His glucose is normal. His temperature, we're going to keep him warm and normothermic throughout the entire course of the resuscitation. And then we're going to get the patient to neurosurgery. So something else that we can consider is actually an antiepileptic. So antiepileptics are important in traumatic hemorrhage where there's a reduction or a change in GCS. So if we want to reduce the likelihood that patient's going to seize in the future, it doesn't necessarily help in the first 24 hours or so, but it does help later on in their course. So traumatic hemorrhage, we can give Keppra or phenytoin. For a non-traumatic, this is less important. It's not actually, at least at this point, recommended by any neurocritical care guidelines to provide that patient with antiepileptic medications unless the patient begins to seize, in which case you can certainly do that. So antiepileptics are kind of a bonus. If you think of it, great. If not, that's okay. So we'll just say in this case, we gave the patient a 20 milligram per kilogram loading dose of Keppra before transport. So we certainly send the patient off to neurosurgery and he gets what he needs. So this concept at the very beginning, the CPP equals ICP minus MAP, is extremely important for anyone with raised intracranial pressure, whether that be from a large brain tumor or a bleed. So let's keep these principles in mind. And the principles, that we use to reduce intracranial pressure, all of these, these points over here are really applicable to anyone with raised intracranial pressure symptoms. So I hope this helps, and I look forward to seeing you guys soon.